can we even move this up even earlier, do you think? We're going to take on transplant, that's the second thing. So do you think there's a future without aggressive chemotherapy?
I don't know. I think there might be. I think we don't have the data to say that yet, obviously, and still we are, I think, curing the majority of patients with diffuse large B-cell lymphoma in the Rituxan era. But we are beginning to identify a higher risk group of patients that we know aren't going to do as well. Those patients with double or triple hit lymphomas, MYC mutations, those people with high LDHs, which I think is still one of the best predictors of aggressiveness of the disease. And you would like to at least consider the possibility of an earlier intervention in those patients, whether it's a couple of cycles of chemotherapy followed by CAR. And I think there are some trials that are beginning to ask that question.
Yeah, I think, if you look both at the time of diagnosis, if you can identify, let's just say, double hit lymphoma, right? And then if you kind of meld that with the PETAL data and you're in your PET4 and you're still positive and you're a double hit, I can imagine a world where I would consider at that time point to take them, and not go to 5 and 6 of if it's dose adjusted EPOCH, and I'm on dose level 3 at that time point, and transitioning that patient to towards a CAR T,
I think though, getting to really lower risk and much earlier patients, we've got to have a better safety profile, and we have to have a financial toxicity profile that's going to fit.
I think the right population is important, but also when you have primary refractory and then refractory to second line, and as the disease grows and it gets more bulky, we've seen now with our experiences that even with bulky tumors, sometimes we see the tumor gets hot. You can see an initial response and everything, but it seems like through some mechanism, maybe T-cell exhaustion or something else, that the relapse rate just seems to be higher with bulky disease, even though you can almost see it get better in a very immediate, maybe even within the first week or so. So that tells us that if we know somebody is refractory, primary refractory, the chances of them being refractory again to the second line and then waiting, that would just mean adding more tumor bulk. And then the chances of that person responding, even then we have seen responders, but if we could catch those people early and intervene early, and there are trials now looking at both obviously in frontline patients who are transplant eligible and frontline patients who are not transplant eligible, but have somewhat of a status, performance status and organ function to get a CAR T. Those trials, when they read out, I would imagine that we would have good results.
So you're arguing for a much earlier referral to the treatment centers, right? So we need to get these patients in faster. They need to be seen at the treatment centers.
So one of the things which we've talked about, at least in our community surrounding and referral practices, is to sort of have the referral early on, because being a transplant and a CAR T center, if someone got started on rice and they had a really good remission, we may be able to have the discussion of transplant early on, and if they are not there, they may be in the CAR T list, but at least that planning can start when they're getting their first salvage, and they could go one of the two ways, rather than waiting till the whole response assessment is done, and then you start that process. You're now delaying the whole next line of therapy.